Welcome to this presentation about pharmacological management of risk factors for ischemic stroke. I am Dr. Jasmine De Leon, a resident physician in acute stroke unit from Khoo Teck Puat Hospital. Together with me is Ms. Melissa Wu, a senior pharmacist from Singapore General Hospital. At the end of this session, one should be able to identify the modifiable risk factors for stroke, and to understand the latest evidence on the management of certain risk factors to help in the risk reduction for ischemic stroke. Risk factors may be divided into modifiable or non-modifiable factors. Modifiable risk factors are those that one can control, treat, and improve to prevent the disease. On the other hand, non-modifiable risk factors are those that are not within your control, like age, gender, family history of stroke, and race. However, knowing that they exist may help motivate you to work harder on the ones you can change. Today, we will focus on the three most common modifiable risk factors, which are hypertension, hyperlipidemia, and diabetes mellitus. Hypertension and stroke. The damage that hypertension causes usually develops over time and is often only diagnosed when considerable damage has already happened to the body's blood vessels. The strain hypertension places to your blood vessel walls predispose them to thrombosis. High blood pressure is the leading cause of stroke and the most significant controllable risk factor. According to the World Heart Federation, it causes about 50% of ischemic stroke and also increases the risk of hemorrhagic stroke. Several studies had proven the relationship of stroke and hypertension. Hypertension is a fairly common problem in Singapore. Slightly less than 1 in 4 Singapore residents between the age of 30 to 69 years have hypertension. The older you are, the more likely you are to have hypertension. In the 60 to 69 years age group, more than 1 in 2 persons have hypertension. In 95% of cases, the cause of hypertension is unknown. In 5% of cases, hypertension may be due to causes such as kidney disease, narrowing of certain blood vessels, or hormonal imbalance. Certain risk factors increase the chance of developing hypertension. These include obesity and diabetes. Based on the latest 2017 AHA categories of BP in adults, hypertension stage 1 is defined as systolic blood pressure of 130 to 139 or a diastolic BP of 80 to 90 mm mercury. Hypertension stage 2 is defined as systolic BP of 140 or higher or a diastolic BP of 90 mm mercury or higher. A blood pressure more than 180 over 120 mm mercury requires immediate medical attention to manage hypertensive crisis. If a person just had an acute ischemic stroke, the BP control is managed carefully for several reasons. Our cerebral blood flow is kept relatively constant across a wide range of cerebral perfusion pressure by adjustment in the diameter of vessel resistance. This process is also known as autoregulation, when CPP is maintained between 50 to 150 mm mercury. In acute ischemic stroke, there is an impaired autoregulation. This may last even until 2 weeks post-stroke in patients with moderate strokes. Studies have shown that during the acute stage of ischemic stroke, patients have the tendency to have a higher blood pressure and may normalize over the span of 24 to 48 hours. Therefore, it is recommended not to lower the blood pressure abruptly, at least in the first 24 to 48 hours, unless we are dealing with the stroke patients with the following conditions: hypertensive encephalopathy, cardiac ischemia, congestive heart failure, compromised vital organs, or a stroke due to aortic dissection. Patients with acute ischemic stroke and elevated blood pressure who are eligible for treatment with intravenous tissue plasminogen activator or RTPA should have their BP carefully lowered to less than 185/110 mm mercury before thrombolytic therapy is initiated. Some observational studies suggest that the risk of hemorrhage after administration of RTPA is greater in patients with higher BP and in patients with more BP variability. For those eligible patients, BP should be less than 185/110 mm mercury before administration of intravenous RTPA. Here is an example of an algorithm for BP management before RTPA. One can use IV labetalol boluses up to a total dose of 150 milligrams. If BP is not maintained less than 185/110, please do not administer the RTPA. Once thrombolized, BP should be maintained below 180/105 mm mercury for at least the first 24 hours. Patients with acute ischemic stroke can present with severe acute comorbid conditions that has been mentioned earlier that demand emergency BP reduction to prevent serious complications. However, it is important to keep in mind that excessive BP lowering can sometimes worsen cerebral ischemia. Ideal management in these situations should be individualized, but in general, initial BP reduction by 15% is a reasonable goal. Patients with severe hypertension, most commonly more than 220/120 mm mercury, were excluded from clinical trials evaluating BP lowering strategies after acute ischemic stroke. BP reduction has been traditionally advised for these cases, but the benefit of such treatment has not been formally studied. Therefore, it was not advised to lower the BP in the first 48 to 72 hours unless blood pressure is more than 220/110 mm mercury. Starting or restarting antihypertensive medications has been shown to be associated with improved control of the blood pressure after discharge in 2 trials. Therefore, it is reasonable to start or restart antihypertensive medications in the hospital when the patient remains hypertensive but neurologically stable. This chart summarizes the recommendation for blood pressure control for the first 72 hours after acute ischemic stroke. Adults not previously treated for hypertension who experience a stroke or TIA and have an established BP of 140/90 or higher should be prescribed antihypertensive treatment a few days after the index event to reduce the risk of recurrent stroke and other vascular events. The choice of antihypertensive drug and target BP goals should be individualized on the basis of pharmacological properties, mechanism of action, and consideration of specific characteristics for which specific agents are probably indicated. Example, extracranial cerebrovascular occlusive disease, renal impairment, cardiac disease, or diabetes mellitus. This algorithm summarizes the BP management for secondary prevention of stroke. Several lifestyle modifications have been associated with BP reduction and are a reasonable part of a comprehensive antihypertensive therapy. These include salt restriction, weight loss, consumption of a diet rich in fruits, vegetables, low-fat dairy products, regular aerobic physical activities, and limited alcohol consumption. Thank you for listening to part 1. Be sure to check out the second part of this presentation. Have a good day.